Hello and welcome everyone. This is Caleb from the National Rural Health Resource Center and the task team. This is our fifth and final webinar for the Learning Collaborative. So thank you to Maeve and the National Rural ACO Consortium for facilitating the last few webinars. Today we are going to review some of the suggestions, education, kind of top points that Maeve went over during the first few webinars, and then talk about some action planning, suggestions, thoughts, and hopefully share some thoughts that different Flex coordinators on the line might have as they start to develop the plan for their state. Before I get started, are there any questions, comments, or thoughts for the good of the team? Again, *2 will unmute your line, or feel free to utilize the chat feature. Well, thank you guys for joining us. And again, thanks Maeve for helping facilitate the first 4 webinars. I went through earlier this week and just went over some things, and I got 4 or 5 pages of notes just on the highlights of things that I wanted to bring up on the webinar, from the 4 main value-based payment options, from comprehensive primary care plus to bundled payments, merit-based incentive payment systems, and Medicare shared savings programs. So I learned that there are many more, I guess, options or opportunities out there for critical access hospitals than we might think or may have previously been aware of. So that was really cool. And then we talked about some of the basics of ACOs, just the establishment from the Affordable Care Act, Medicare providers can participate in shared savings, how many covered lives and quotes you need to participate, the commitments, time frames, how long you need to do that, the opportunities that providers have for training and population health, and again, the many models. On the first webinar also, Maeve talked about the different quality measures and prevention, caregiver experience, care coordination, and patient safety, and then at-risk, the measures for at-risk patients. And that led further discussions later on into the importance of billing and coding specifically with those HCC codes, and how if you don't code in quotes appropriately, then the payers, Medicare specifically in this example, loses the ability to understand the entire complexity of that patient, and thus will place that patient into a different risk category, and that will affect, or has the opportunity to affect, reimbursement. And please, Maeve or anyone, interrupt me if I misspeak or failed, don't highlight something, or we want to go further in depth, or if anyone has any questions. We talked about the core elements. Go ahead.
Oh, Caleb, this is Maeve. I was just saying it sounds good so far. You're right on track.
All right, great, thanks. Talked about the core elements, from care coordination, prevention, and getting and utilizing accurate population health data, and all of those things are what get put into the top of the funnel. And with those things maximized and managed and helped and improved, then success in a value-based payment structure or program is what should come out of the bottom of that funnel. So there are different categories of ACOs, and from quality metrics and prevention to costs and electronic health record requirements, advancing care info, which was a bigger percentage than I thought, at 25% of the of the formula. And then the fourth category was transformation. The financial stability of the transition to value was also discussed as we talked about the billing codes. And that was another thing that I found really nice and great and helpful, is that there are billing codes now that allow hospitals or providers to bill for some of these preventative services or population health services that historically have not been covered. So even if you're not part of an ACO, or even if you're not doing everything, you're able to start billing for and being reimbursed for these services. And I think that's a huge win, regardless of where you are in that path or transition to value. So I thought that was absolutely worth noting. Maeve talked about the National Rural Accountable Care Consortium, or collaborative, what they do, the resources they have available, the training, the care coordination, teaching billable population health, the evidence on attainable payment choices. I may have not been able to read my notes there, but alternative payment models, improved coding. So Maeve, do you want to talk a little bit more off the top of your head on anything else that that you guys do, or resources, or how to contact you, other than, and we'll be sure to put your and the consortium's website in Moodle so people can reach out should they have any questions. But
yeah, I think that's a really good point. The only other point that I would add to kind of our resources is that, you know, for your practices that are going into an ACO in January of 2019, if you have anyone who's looking for help, they do have to be in our program at least 3 months for us to work with them. So send them my way sooner rather than later. And then we are grant funded through September of 2019. So we're helping practices, new practices, through probably January of the coming year, and then we'll ongoing work with them in 2019, but can't take new enrollment probably after January of this year. So just a little caveat on the timeline there. But in the meantime, I also want to reiterate my offer. I'm happy to do webinars or other technical assistance for other Flex coordinators if you want more information on the program, or want to know a little bit more about kind of who in your state is already working with us and what the scene is there. Please feel free to reach out to me via email or phone. I'm always happy to talk.
Thank you. Maeve talked about the core elements of advanced payment models, the different categories that we just went over, as well as provided additional data sources where you as a Flex coordinator might be able to find some of that state-level data engagement within your state. So I encourage everyone to, when you have a chance, go back through either just the slides and thumb through them, or listen to the presentation if you've got time to devote to doing that. On the next webinar was the third webinar, Prepping for Value-Based Pay and Core Elements of Advanced Payment Models, or Alternative Payment Models. And that was types of TA needed, which I think is really important for us as we think about the Flex program's role and the state office's role in that transition to value, and how we can best support the critical access hospitals. So there's structural TA needed or available, and that is really getting that foundational understanding of what alternative payment models are available. We went over some of those before, and whether or not your providers are subject to MIPS, what that means, how you report data, who you reach out to for TA, and getting access to that data. And then one of the other things I think is really important is connecting with others who are interested in this. So the great thing about this transition to value is it's not and shouldn't be a transition to value for the hospital and the hospital by itself. This is a transition to population health, to engagement with other community or statewide or national stakeholders. And that's really exciting, and one of the things that I want to reiterate on this webinar is, as well as everything else we do, the great opportunity that you guys in the Flex programs and the state offices have is as a convener of those interested parties. It's I was just in a meeting with the federal office, and great praise was given to the opportunity that state offices of rural health have to be that convener of different partners, be it hospitals or clinics or public health or whatever it is. So I think that's one of the really big wins that state Flex programs have. So I wanted to make sure to highlight that. One of the other types of TA that's needed is just incompetency, just in the quality of the measures, improving quality outcomes, the accurate data, how to submit, how to code, as we talked about, but also how to mine that data so you're able to review it and look at it. As we discussed, there's a business and a financial case for this. For the longest time we heard, yeah, we like the idea of population health, but we're not being reimbursed for that. There's no billable code for that procedure. Yeah, we have to provide information on how to, how to use your nebulizer for nebulizer treatments, but there's no code for that. But we're starting to see that change, as Maeve discussed, in many different ways. So there are resources to help provide education and resources around the business and financial benefit and case for starting this transition. And then just delivery reform. It's a change of mindset as well to start thinking about, for lack of a better word, population health and wellness as opposed to, health care as opposed to sick care. And some of that information and education needs to be provided, so there's another opportunity. And again, alignment opportunities with Flex, so quality improvement is already part of the Flex program and the MBQuip program. So how can we utilize what's already there and add into it these aspects of the transition to value? The financial and operational improvement, so many Flex programs are already working with financial and operational consultants to do on-site visits or just review some data and help facilitate some of those conversations. We don't expect you guys to be experts after 5 or 6 webinars and discussions on transition to value and alternative payment models, but knowing at least how to initiate and have that conversation is really, really helpful. And there's always experts to have those in-depth conversations when they need to be. And then just the innovative models that are available in the Flex grant to be able to reach out to your state partners and programs and identify opportunities within your state, and then work with your project officer to identify an appropriate, applicable, innovative project in your state. That's a great opportunity that the Flex program has that not a lot of other grant recipients have. It was stated in this meeting today that the Flex grant or ORHP is one of the only funder in the government that does not prescribe exactly how projects and things are going to be done. So things can be done differently in Kentucky, where Kayla is, and where they need to be done differently than Stephen's projects and programs in Missouri and Stephanie's in Idaho or wherever we are. And that's a really great opportunity. So the fact that we can work with our federal partners and make sure our programs and services reflect the needs of our state and our partners is a great win, and I just wanted to make sure to take note of that. So we have, a bunch of different examples of that because, again, Kayla's doing different things than Mary is and then Stephen is in Missouri. We talked about the risk adjustment discussion a little bit, and we touched on that earlier, but just it's a huge, it's a big opportunity, I think, that's been missed historically, especially in critical access hospitals and probably rural health clinics as well, just in quotes undercoding, because it didn't really matter if all of the comorbidities were charted and tracked, because if I'm being paid cost, it costs me the same to provide care to a diabetic patient with a sprained ankle as a non-diabetic patient with a sprained ankle. But there are complications and things that providers need to keep in mind that get missed if that's not charted and tracked appropriately. So there's an opportunity there for education for staff, as well as quality directors and billers and coders to just ensure entire patient information is gathered. And for another reason, it helps the next doctor down the road get a complete understanding and chart of the patient, which provides for better care. You're much more likely, you're much more able to capture something and be able to treat and manage if it's charted and tracked. So that's the hierarchical coding categories, or categories for care, something to that effect. So the risk adjustment factors, I just have a note here that that's very important. So I wanted to highlight that. And so Maeve also provided some proposed interventions. So transitions of care collaboration. This is something that's of real benefit between hospitals and clinics, hospitals and nursing homes, hospitals and home, anywhere that patient, inpatient or outpatient, is going to go. Just those communications can absolutely be improved and can be strengthened. So transitions of care collaboration, data gathering on population health. So there are a bunch of available data sets, as well as opportunities within each state to gather some of that data. But the types of programs and services made available by the hospital or the public health office in the county and supported by the hospital should reflect the needs of the community. So if you have a very high population of patients with heart disease in your community, but a really low incidence of diabetes, then the programs and services and opportunities for patient and community education should reflect that in some way. So there are great ways to start mining some of that data from community health needs assessments, if the hospitals in your state have facilitated those, if they're 501c3s, or any of the for-profit institutions that have done that voluntarily. Those are a great source, as well as I think the Robert Wood Johnson Foundation has a bunch of population health data. Community health rankings is another source, and I believe Maeve's slide had some links to other data sources. Another plug for one of the center's resources is the Population Health Portal on our website, and that is a self-assessment that a facility can take to see kind of where they are in the effort or readiness to implement population health services. So if there's not a resource to that, Shannon, will you help me remember that I'd like to put a link to the population health portal in the Moodle stuff?
No problem.
Thank you. What else do I have? So state strategic planning for population health. So based on all of those things, it's a good decision or a good idea to convene some of those partners, as we talked about, the hospital association, the Office of Primary Care, the public health office, and say, hey, these are the type of things that I'm seeing in these communities. What are projects that are already happening that we don't need to duplicate, that we can lend some support to, even if it's just putting notices in our monthly newsletters and sending emails out for webinars or attending conferences to make sure my office is up to date on those. So there's a bunch of opportunities for that. But there's also strategic planning for your office and for the state moving forward as well. And the more information you have to inform the programs and services that come out of your office or that your office supports, the better poised you are to have success in those projects. And then the development of a network for value-based pay, a consortium or a team. But I think similar to the discussion of gathering your state partners, it's a great opportunity to talk to EMS entities and the hospital association about, hey, what are the hospitals saying from your point of view? Sometimes the hospital association can lobby where your office cannot because of where it's located in state government or what have you. And then again, Maeve highlighted a bunch of different data sources for that. So I will refer you to those slides in the Moodle, what do we call it, the web world, to wander through there and access some of those data sources. And as always, if there's data that you're looking for that you can't find or doesn't exist but you wish it did, always let us know. I can't promise that we can find it if it doesn't exist, but odds are if you're looking for it, someone else is looking for it as well. So if it is out there, we can help you find it. If it's not out there, we'll be sure someone knows that it would be helpful if it were to exist. So some of the suggested next steps that were discussed in Webinar 3 were examining the survey responses. So we put together a little SurveyMonkey survey for everyone to distribute to their critical access hospitals to just get a good, rough, quick, easy sense of where they are in the transition to value now. So I think that's a great starting point. So seeing what the hospitals who responded said and seeing where that compares to what you thought it might be, I think is a great place to start. And participating in the Learning Collaborative as well as those survey results should hopefully give you an opportunity to develop your next kind of steps. So populating a template state assessment. Are we ready? What are those next steps? Do we have enough hospitals that we're ready to start talking about this, or do we not have any hospitals who really know anything about it and they're not even submitting MIP stuff? So we need to back up a little bit before talking about joining ACOs or creating a collaborative. Let's work with our QINs. Let's identify who's not submitting MIPs and see what we can do to get on track with some of the requirements that are happening now. I think all of those things are good. Another opportunity that was mentioned or brought up was a state resource guide. So identifying those state partners, the QIN, the hospital association, whomever is participating in, providing TA, aware of, or engaged in this world of the transition of value and the alternative payment models, if that's MIPS education or the ACO that's over there, or if one of your private payers has begun working with value-based payment reimbursement as opposed to just volume. Those are all great places or great resources to have in a guide that you're able to provide. And maybe that's a webinar and maybe that's a pamphlet, but or just a page on your website. Those are good places to start. And our last webinar, Maeve talked about, implementing a plan, and it was really just a great way to combine all of the education and information that she laid out in the first webinars into, all right, so now I have all this, what do I do? And the first step in creating a plan was identify the top 3 needs for your state, for the critical access hospitals. So is that MIPS education? Is that resources? Is it, what is it? Is it just the base fundamental what did we call it? So we use the same words. The structural support or understanding of value-based payment models. There's a ton of different things, but identify those top 3 things and start looking at where those are. And then identify your partners, if that's state organizations, national organizations, other state offices of rural health. Maybe there is a big private payer in your state that handles all of it. Maybe you have a big system. Many of the states have coverage of almost all of the critical access hospitals. So reaching out to the mothership and saying, hey, we want to make sure we're supporting you guys in your needs. What does that look like? We would like to have you guys at the table as well. So we're making sure any program or education that we promote jives with your guys' messaging as well, so we're not working at counter angles. And then just identifying those communication opportunities. If it's your annual rural health conference, webinars, having someone come speak to your hospital. I'm similar to the Learning Collaborative. I've never reached out to anyone about anything rural for a webinar, for a phone call, and been told, no, I don't want to share, I can't talk about that, especially when it's talking about the transition to value, better care for less money. Everyone's excited and interested about that. So identifying where those opportunities are and finding those partners or individuals who can help support your needs in providing those that education, whatever it will be. And we're us here at TASC, we're absolutely here to help you in that identification of, all right, so I've got the survey and I've got some public health data, but I don't know what to do with it. And give us a call and we can help walk you through how to, how to start, how to get started. That's sometimes the toughest step. 1 second, I'm going to take a drink of water, breathe. Any questions from anyone? All right, hearing none. So yeah, this is my next point is just based on some of those opportunities. So identifying partners. I've got hospital association, rural health association, primary care association, state Medicaid, insurance companies, quality networks, HRSA networks, what activities to support. So what's going on now that you can support? What has happened in the past? What's going to happen? How are your partners and how have they responded? Has it been favorable? Do you have hospitals who are interested but scared, or have there been any that tried to implement an ACO and it didn't work out? They had just enough lives and they had to have 3 or 4 different hospitals combined to do it, so it didn't work, so now they're leery of it. The surveys are a great opportunity for that, and just reaching out to your providers is a really good way to do that. And once you have that kind of base fundamental data, kind of state of the state, then you're able to say, oh, well, there's an opportunity for us, there's an opportunity for them. Let's get together and see what we can do. And that brings us to today, where we review the teachings and education that Maeve has outlined for us, and then we hopefully chat with some of the Flex coordinators on the line and see if you guys have had an opportunity to identify any next steps or areas that you might need to focus on, or education, data, resources that you need to start to think about your next steps. So do we have any brave souls willing to volunteer? Or do I have to call on Lisa from Georgia and see if she's still able to talk?
Caleb, this is Mary Sheridan from Idaho.
Hey, Mary. Hey, Mary.
I am happy to get this started. We, in terms of our next steps, we have already scheduled a meeting with our QIN, which is Qualis Health, to really better understand the work that they're doing around educating critical access hospitals and rural health clinics in Idaho. We know they're doing the work, but we've never really had any focused conversations. So we would like to get their perspective not only about what they're doing, but where they see critical access hospitals on this continuum in Idaho, to help us then understand and discuss maybe some future partnership opportunities for us, or where maybe our Flex program and State Office of Rural Health can maybe align with their initiatives. So we already have the meeting set up, so we're feeling really good about that in terms of our next steps. We're also going to start doing an inventory to get a baseline around where critical access hospitals are. Those that have completed a community health needs assessment, just as a starting point. We don't have that inventory, and we'll do that as part of our site visits for Flex. And we're also going to then revise the sub-grants that we offer competitively for critical access hospitals when our Flex grant begins in September. And we're going to offer a category of population health and require that they complete the population health assessment as part of the application process. So that's what we're doing. That's what we have coming.
That's great, Mary. Well, we'll follow up with each participant of the Learning Collaborative to discuss action plans, and then I'll facilitate a RAP interview, the recommendation adoption process interview with each one of you guys participating, to see kind of where you're at in 3 months and then 6 months, and that helps us inform our activities for the Learning Collaborative, as well as identify resources and TA while you're going, so we're not just doing this education and then sending you out into the world without any support. So I'm excited to hear about that, and be sure to let us know if there's anything we can do to help support that, or if there's any resources we can help provide.
That sounds great. Thank you.
Thank you. Anybody else want to share? That was great, Mary. Thank you. And don't be intimidated by the list of things that Mary had either.
Mary had some great ideas, so in Kentucky, I think I'm just going to from her. We used to have a really good relationship with our QIO. I would like to reach back out to them and see if we could form sort of a new relationship. The people that we worked with there have since left, and it's just sort of been in limbo. I don't keep up with them like I should. You know, I get their newsletters and stuff, but that's about the extent of it. I'm going to start, you know, when I do the hospital visits, talking a little bit more and asking a little bit more about where they are with population health, you know, ACOs. Have they ever even considered that? Are they, you know, looking into it? Like I mentioned, I think on one of the calls, our Kentucky Regional Extension Center, they're already doing a lot of this education. So I'd really just like to check in with them and see where we could help them or partner with them. And they actually reached out to us last week about partnering on some stuff with the SHIP grant. So I think it's absolutely perfect timing, and they have, you know, a much better knowledge base of this stuff than I do, even though I feel like I'm much better off than I was before starting this collaborative. So it's been really helpful. But I think probably my next step will be to do sort of something similar to the survey that you all sent out before, and just get a feel for and let the hospitals have time for everyone to complete it, because I know we didn't have that many complete it before. So I'd really like to get better participation, give everybody a little bit longer time to finish that. So that's sort of my next steps and wish list. I want to go back through the webinars, through some of the documents that you all sent out. I think I missed the last call, so I want to catch up. And that data set, I definitely plan on going back through that again. That was great, and I think will really serve me well, you know, just in all kinds of facets. So it's been good. I've enjoyed it, and that's sort of what I plan on doing next.
Awesome. Absolutely. I think those are all, and I think it makes sense, and it, you know, follows on, like you said, your rural health center is already doing a bunch of this stuff, so why do it yourself if they're doing it too? So just reaching out to them and seeing where you can help support and collaborate, that, you know, that's the name of the game. So that's the type of thing we like to hear. Who else would like to share?
Hey, Caleb. This is Steven Jenga with the Missouri Hospital Association. And this has been a very eye-opening collaboration, may I say, because there's several things that we will be focusing in the coming weeks and months. And one of them, just to highlight from the get-go, is a little bit more education or where we stand as a state with the critical access hospitals, specifically to the C-suite, the CEOs and CFOs who completed the survey that you sent to us. And we do see a gap and opportunity to help ensure that those that have not started thinking through the implications of the programs like the MIPS programs, think through in terms of how it's affecting them today, how it's going to affect them in the future, because it's not going to get any easier if they don't change the course. So we will spend some time on there, and we have a meeting which is scheduled for August the 21st, where we pull all the CEOs, CFOs, and the quality directors for the whole state for all the critical access hospitals. And this is information that we will for sure share with them and try to shed some light and try to solicit their input on the challenges they are facing and what we can do moving forward. The next thing to the process is, as I mentioned, probably at the first week of this session, is at the Hospital Association, we did send a survey to all hospitals across the board, and there was very good participation in response from the critical access hospitals towards the end of last year. And one thing that we wanted to identify is where are they in the continuum in terms of population health maturity scale. And so we had a host of questions that we had asked on that survey. And when it came back, we did an analysis and we were able to identify where they fall on the different levels of the population health maturity scale. And with that said, if they fall on the top, the middle, of on the lower spectrum of things, there are key strategies that we had identified that would be appropriate for them. And so right now, as we speak, we just send the results to them and explaining to them what it means to them. And we will be working with them moving forward as well to help close the gaps, to make sure that they are well positioned to be able to integrate all the different aspects of population health in what they are doing to ensure that they are successful in the future, as that's where the landscape is facing. So that's a few of the things that we will be doing.
That's great, Stephen. That's really, I'm excited to hear about that population health thing. I might be reaching out to you to see, to get some ideas on some of those key strategies based on where they fall in that continuum, like you said, top, middle, or low. Yeah, that's really exciting. I'm excited to hear how the conversation goes in August with the CEOs and QI, CEOs, CFOs, and QI directors, and I'm sure we'll chat. Well, we'll see you next month at the reverse site visit. But be sure to let us know if there's any resources or education or info we can help provide as you prepare for that meeting.
Absolutely. Thank you, Caleb.
Yeah, thank you. We've got time for a few more. If anyone wants to chat or has any questions on their, kind of expected next steps. Laima or Jada? Again, *2 will unmute your line.
Hi, this is Jada.
Hey, Jada.
As far as next steps, I think we're pretty far along in the process as far as a lot of the hospitals setting up an ACO. I'm actually expecting my first invoice from the hospital association, since we are assisting with that buy-in that the hospitals have to pay. I think it's
awesome.
How much it is. We're making it work, and a lot of them are actually a surprising number actually decided to go full.
Oh, that's great.
Even last year, yeah, it is, because we had a lot of resistance at first, but even last year we had a few that did. I guess it was just a little bit of a sampling where they bought in, but they were not there. There was no penalty. So this year they're continuing on in the hope, and we're doing I guess with hospitals where they're forming their own consortium. So that might not be the correct terminology, but they're moving forward, which is the important part. So that's kind of where we are.
That's really cool. I'm excited to hear about that.
Yeah, I'm excited too, because like I said, we have
a
lot of resistance.
Wow. Awesome. Sure to let us know, and like I said, we'll be in touch, but be sure to let us know if there's anything we can do to help support or anything. That's really cool.
Okay, great.
Lima said she actually accidentally hung up. Worries if you can still hear us. We've got just around 10 minutes or so. So Lima, if you're on, *2 will unmute your line if you'd like to chat about your guys' next steps or action. And it looks like she's typing in the chat box, so I'll let her do that.
Hey, Caleb, while she's typing, this is Lisa in Georgia. I'll just be quick. What everybody has added to the conversation has really triggered even more thoughts on what we need to do here in Georgia. But the first thing I'm going to do is reach out to our current rural ACOs and just try to understand best practices, what they've learned, and how do we share the results that they've had with our other critical access hospitals to engage them even in the discussion. So I think that's my first pick. And then the other is that billable population health portion of it. We have other programs that I'm going to link that into to make sure that we are focusing on those opportunities for our primary care docs to take advantage of.
Awesome. I think those are both great steps. You know, engaging those who are already here, doing some of that work, seeing what you can, you know, steal in quotes from them to share with the others, even if it's information about their project. And then that billable population health, those linkages, primary care is absolutely the place to do that. That's great, Lisa. As we wait for Lena to dial back in, I will let everyone know that we're looking for action plans around the 9th of July, so a little more than a week from now. And there's a template that we've provided in the download portion of the webinar today, and it's available in Moodle from last week, as well as it'll be there for this week as well. And it's really just an opportunity to kind of write down some of those things, keep track of what you guys thought you were doing, kind of those key partners and who's responsible and how you're going to measure that success. You know, for some of those examples, reissuing the survey that Kayla mentioned, you know, if that's going to be done by the end of the project year, you know, and that's on an action plan, it's really easy to say, oh, Kayla, we'll reissue the survey by the end of August, and give, you know, 3 weeks or whatever it is with a couple email reminders to CEOs or whomever to complete the survey. And it's easy to check off the list and keep track of. And then when you follow up with me in 3 months, that action plan is what I'm going to be asking you questions on and about. Kind of how's it going? What are some of the things that you've found on that? What's going well? What are things that you found that you didn't expect? And then, as always, what resources can we help provide to make sure you're getting all the things marked off your check sheet that you'd like to? And then just a reminder that, and I think everyone's examples and suggestions are absolutely great. They're not implement an entire new project and program where we go out to every hospital and initiate ACOs and implement them. It's reaching out to state partners, reissuing a survey, just kind of finding out what's going on and meeting and identifying and meeting those needs in your state where they are. And I think that's exactly the type of thing that we're looking for. You know, we know and understand that this is in addition to your already established activities, but we think it's important, and we appreciate that you guys do too. So we think there's definitely an opportunity within what we're already doing to initiate that conversation at the least.
Hi, this is Lima. I dialed in back in. Can you hear me?
Hey, Lima. Welcome. Thank you.
Okay, so we've been really closely working with the Health Insight. They come to the meetings, our quarterly meetings, to Quality Improvement Network, and they just had a great presentation on the really simplified and explained to quality improvement managers on the importance of value-based care and how it will work when it will, when how to move forward this. And we actually talked about having the same presentation for the, we have twice, every year we have twice hospital administrators and CEOs come all into one room together, and this would be, we figured that it would be a really great presentation for them also. So far, we're really moving towards the improving our measures of quality of care, and also we have a couple of hospitals coming up for them timing time for them to have a community health needs assessment. So we think while performing this, we used to help community health needs assessments and kind of putting more burden on hospitals to come up with a couple of come up with the improvements. How can they reach out to the community to like the action plan, I guess. And now probably we decided to be more helping them with action plan and guide them through a little bit and give them more support, more technical assistance. And I also really like the idea of requiring population health assessment as an incentive to providing some services.
I like that idea. Awesome. So yeah, I think those all make really good sense. And I think the one thing that goes through all of the connecting with the QIO, the QIN, I think that's a great step. You know, they're connected already with doing the MIP stuff, but they're a great resource. And unless things have changed in their contract, or their work, you know, I think it's contract is how to phrase it, guidance. You know, they're required to have a certain amount of their work reach rural. So they have an interest in working with you guys, and you have an interest in working with them. So I think it's great that that everyone on the call, excuse me, has mentioned working with their QIO, and developing that relationship if it's not as strong as it once was, or if it could be. And I think that happens. You know, people leave an office, and personalities change, and things are dynamic, and you know, that happens. So I'm really excited. So we got just a couple minutes left. Are there any other comments or questions, or did we get to everyone? Did everyone get an opportunity to share some of their next steps or expected next steps as we look toward completing our action plans by submitting them, emailing them to me, Caleb, CSIEM, @ruralcenter.org, and you'll have an email address for me and many links by the 9th of July. Again, action plans due to Caleb by the 9th of July, please. What other questions, comments can we help you with while we've got you on the phone?
Caleb, this is Lisa. Will there be an opportunity, you know, as we've done our action planning, to reconvene, or just even on that Moodle site, for us to, you know, see what everybody learns, you know, maybe a few months from now?
Absolutely. So I'm going to keep the Moodle, the web platform, open as long as I can. And I think it's a free web-based service that we're using, so it shouldn't go away anytime soon. But absolutely, I can lobby for another webinar, at the very least, to discuss amongst ourselves. But as with everything with TASC, this will not be the last time you're asked to speak about or to talk about your learning collaborative. We're going to ask you guys to talk at the Flex workshop or at the reverse site visit next year, or whatever it is about your participation in it, and or about some of the benefits that came out of it, or things that you learned that you didn't expect to. But we want to provide that opportunity for you guys within the group as well. So I can all but guarantee, I love making guarantees without prior approval, but I can all but guarantee that I can get us a webinar to chat about it. Like I want to hear about Stephen's and Kayla's and Lisa's and Lena's projects, and I imagine you guys are as excited about it as I am. So yes is the short answer to that, Lisa.
Thanks. It sounds like great stuff that everybody's doing.
Yeah, I think so. All right, last call. Otherwise, I would like to thank Maeve and the National Rural Accountable Care Consortium again for helping us put this learning collaborative together. It was great working with you, and we really do appreciate your information, insight, and expertise in this area, and look forward to working with you again.
Thank you. This has been my pleasure. It's so exciting, I think, to hear kind of how every state is doing something a little bit different, but taking a step forward. And definitely reach out if there's anything I can do to help in the future. So big thanks to you.